Nick Majerison here. Welcome to Top Med Talk and welcome to part 2 of the Perioperative Care Practicum taster session. This is a collection of highlights from the last Perioperative Care Practicum recorded at EBPOM USA in Atlanta, Georgia, earlier this year. These talks follow on from yesterday's podcast, and what you're going to hear today is, in this order, Desiree Chappell, CRNA and board member of the American Society of Enhanced Recovery, TJ Gann, professor and chairman at Stoney Brook in New York, and the immediate past president of the American Society of Enhanced Recovery, and also Dr. Tim Miller, anaesthesiologist from Duke University Medical Center. They're presenting their talks which form the Perioperative Care Practicum. One of the reasons we've put these podcasts together at this particular moment is because Top Med Talk is coming live from the Chicago Masters course, a Perioperative Care Practicum at the moment. Go to the website now and listen live to the world's most cutting-edge thinkers and pioneers in the world of perioperative medicine, www.topmedtalk.com. Oh, and sign up for our mailing list as well. I'll tell you more about that after we have a listen to this.
Top Med Talk.
So, I am Desiree Chappell, and I am a CRNA, and I've been in practice for about the last 10 and a half years at Norton Audubon Hospital in Louisville, Kentucky. Now, I've been a project team leader there over the last several years, or actually a little bit longer than that, but when Enhanced Recovery came to us about 5 years ago, I took the lead on that, and once I started seeing the benefits of it, I got involved in not only our anesthesia team, but in the hospital initiative, the system initiative, and now, as Monty said earlier, I am involved on a national level with the American Society for Enhanced Recovery and also with EBPOM in the meeting this weekend. So I'm not coming to you from an academic setting like many of the people that you're going to hear this weekend. I work in a small community or medium-sized community facility. I'm not a researcher or a scientist. I haven't done any randomized controlled trials. I'm not going to quote my own studies or share with you a litany of studies and detailed protocols. I'm just like many of you, sitting on the stool, delivering anesthesia 40 hours a week, utilizing enhanced recovery in my everyday practice. Now, I've listened to the world authorities that you'll hear here this weekend, and I've read the literature, and I'm convinced that enhanced recovery is best practice. But what has changed my mind, changed my practice, and inspired me to become involved on a national level, and really what fuels my passion and excitement and enthusiasm for sharing my experiences has been the first-hand view of the immediate difference that enhanced recovery has for our patients. And it's rounding on that colorectal patient or that joint patient on post-op day 1, and they're eating and drinking, and they're walking around the nurse's station excited about their progress and their steps. And they're smiling and they're laughing. And I know that because we changed our perspective in our group, in our hospital, and we changed our practice to include enhanced recovery, their outcomes are far better than if we hadn't. So today I want to share with you some experiences I've had and as I've met others across the country that they are having and that you here are as well, right? We're all kind of in this journey together. We're going to talk about the amazing successes that we have, but there are lots of challenges that we face too, and we'll talk about those. And I also want to be very optimistic about the future of enhanced recovery and perioperative care. So I do have a couple disclosures, not so relevant. It's the big green button I always forget. All right, so when you think of Kentucky, it's Derby season. You're going to think of these beautiful rolling hills with all of our horses, and of course our booming bourbon industry there. But what you've probably heard a lot about Kentucky in the news recently is the drug epidemic in our state. We are in the top 3 for drug overdoses in the U.S. right now. But what I'll tell you is probably killing more people than drugs, guns, and cars combined is our obesity problem and our continued issues with smoking. It's definitely an issue. So that has led to the state of healthcare in the Commonwealth of Kentucky. I show this slide all the time and I ask, is this exclusive to what we are taking care of at our little hospital in Louisville, Kentucky? Absolutely not. Everywhere across this country and across the globe are taking care of sicker, older patients with lists and lists of comorbidities. And we're going to talk about how to optimize some of those this weekend. But when we took a step back and started looking at enhanced recovery for our patients, it wasn't just about being good stewards of our healthcare system and costs for the hospital. It was about improving care for our patients, improving outcomes, and really improving the health of our community as a whole. So, about 4.5 years ago, Dr. Shanahan, who's pictured here on the right, brought enhanced recovery to our facility, and he aptly named it ERAS in the Bluegrass, which is catchy and great when you're doing that internal marketing and trying to create a little engagement. This is our core ERAS team up here in the corner. Dr. Patrick Shanahan, one of the medical directors. Dr. John Rowan, who's not pictured. He's an anesthesiologist that helped us get this going. Myself, Carrie Cheshire, our nurse practitioner from our PAT, or pre-admission testing clinic. She, by default, became our enhanced recovery navigator. And we all know that it takes this multidisciplinary team to make this work, right? You have to have a coordinator or a navigator as well, and she was that person. And then Dr. John Walker, who is one of our general surgeons who's been practicing for the last 35 years or so. And he said he will tell you, you can teach an old dog new tricks. He was completely convinced. He was our first surgeon on board, and he still is very proud of what he is doing with enhanced recovery in his patients.
Top Bed Talk.
Patients' experience on pain. There are 3 studies, all using pretty similar methodology. The first one was done in 1993 by Carol Warfield from Boston. And then Jeff Effelbaum and I did the second study in 1999, and we repeated it in 2012. And you can see that the survey was very simple. Simply ask patients, what was your experience on pain following surgery? And again, you can see that most of the patients obviously have pain because they had surgery. But what is more alarming, if you look at over in the severe and extreme, those who experience severe and extreme pain, they are almost 30% of our patients. So these are people coming up of operating rooms screaming. Now, certainly, we don't want our patient to be in that category. And even though they are different population, you can see that we still have an important job to trying to reduce those patients more towards the slight and moderate. Now, in that same study, we asked patients, what were the side effects or what are the adverse events that you don't like? We never mentioned anything about opioids. Just tell us some of the side effects you experienced. Now, if you go through each and every one of the side effects that the patient mentioned, almost every one of them could be attributed to opioids-related adverse events. From nausea, drowsiness, sleepiness, constipation, vomiting, itching, urinary retention, almost everyone could be attributed to opiate-related. And again, this is without prompting the patients. So clearly, although opioid works well, but it potentially can come up with a lot of side effects. And we also know that poor management of pain can result in significant consequences in the process of recovery. Those patients who are teetering at their myocardial consumption potentially can get myocardial ischemia, MIs post-operatively. And patients who have pain can't go to sleep well, they can't rehabilitate well, patients who can't breathe adequately, they get infection, they get pneumonia. So there are a lot of issues with poor pain management. And we also know that now we understand the phenomena of chronic pain that often can result from inadequate treatment of acute pain. Now, in the old days, the model for our pain management has always been that if you have a little pain, I give you some opioids. If you get more pain, I give you more opioids. And if your pain is really extreme, guess what? I give you even more opioids. And you may chuckle, but this is really what a lot of us in the perioperative physician has been using, because we use a lot of opioids. And in particular, I think in the United States, far more so than other countries. I spent a number of years practicing in the UK. Coming over here, I was amazed how much opioid we tend to use, and without thinking about some of the other non-opioids. And there is recent data suggests that 1 in 10 of drug addicts, people who are addicted to opioids, they got their first opioid from either acute episode of pain or from surgery. So these are some of the people that we see every day. We potentially given opioids, and you may remember I had a very minor surgery. I was given 90 pills of OxyContin, right? And you take the first pill, and the next thing you found that you are praying the porcelain bowl, puking your guts out, and that was it. The 89 pills sits in the medicine cupboard. And guess what? People who have access to it can potentially become addicted to opioids. So this has been a challenge. Every year, every day, in fact, 90 people die from opioid abuse. Think about that. Now, not only that, in the hospital, we see a lot of opioid problems. And this is from a Premier database that we mined a few years ago. And when we looked at opioid adverse events, those patients who had an opioid adverse event, and looked at how their recovery, what was their length of stay, what was their complications. And again, you can see that those patients with an opioid adverse event not only increased, their length of stay increased from 4 days to overnight about 9 days, and their cost of that episode of hospital admission increased substantially. So it's not just the opiate events, but it also increased costs.
Top Med Talk.
When we're talking about enhanced recovery, the majority of enhanced recovery pathways are major abdominal surgery. And I think the gut is particularly at risk. If you have episodes of hypovolemia, one of the first things you'll do is shut down your splanchnic circulation to maintain your core circulation, to maintain blood pressure and perfusion of your vital organs, your brain and your heart. And I can't tell this story without the anecdote of Monty's study, which is probably about 25 years ago now, when Monty was maybe longer. I don't want to age you, Monty, but when Monty was a keen resident, they decided to do a study on each other where they put in arterial lines and 14-gauge catheters and bled out 25% of their blood volume. Probably wouldn't get IRB approval these days. But what they found is that heart rate and blood pressure didn't really change, whereas to compound the misery, they also put nasogastric tubes down each other and measured their splanchnic perfusion. And when you lose 25% of your blood volume, your stroke volumes, if you measure a flow indices, drops, and your splanchnic perfusion drops when your blood pressure maintains normal limits. So one of the first things you'll do when you become hypovolemic is shut down your splanchnic circulation, which is bad for GI perfusion. More commonly, if we give too much fluid, you get that little bit of puffiness under the skin, puffiness around the bowel wall, and bowel wall edema. And that is also associated with adverse outcomes, and there's been a number of studies in the restrictive arena which have shown this. Perhaps this most well-known one was by Brandstrup. It was called restrictive study, but notice I put that in inverted commas because this study really showed the dangers of fluid excess. So they had two groups. The only thing they changed between the two groups was the fluid management. You can see their restricted group had about 2 to 3 litres of fluid on the day of surgery, so about what we would think now as a sensible amount, whereas their liberaler group had the old-fashioned 7.5 to 10 mils per kilo per hour of fluid. So they got 6 to 7 litres of fluid on the day of surgery. Those were those patients who were 6 kilos heavier than they were the day before. And notice the difference in complications just by changing the fluid regime, halving of major and minor complications when we avoided fluid excess. So this led to this paper by Daniel Chappell, and this is the approach that we largely follow at Duke, suggesting a rational approach to fluid therapy, and just the title alone suggests that he thought behaviour before this was irrational, which I think it was. The maintenance fluids should be, crystalloid we use on a pump, approximately 3 mils per kilo per hour based on ideal body weight, to replace your whatever deficits you have. I think they're fairly minimal now in enhanced recovery, insensible perspiration, urine output. And he also goes into some detail about how there is no such thing as the third space. If you want to read the paper, you can read more about that. But basically, fluid is either intravascular or it goes into the interstitium. We don't need this concept of an all-consuming third space where fluid disappears. And in some patients, that's enough. But in many patients, if you want to individualize fluid therapy, you can do goal-directed fluid therapy. And this is what we do at Duke. We use a colloid. I think the evidence for that is weak. A crystalloid is an alternative approach. But you try and individualize your fluid management. So why goal-directed therapy? Well, as I've mentioned, we've used blood pressure for many years. And back in as long ago as 1928, they said it's a source of regret that the measurement of flow, i.e. stroke volume, is so much more difficult than the measurement of pressure. This has led to an undue interest in the blood pressure manometer. I.e., in Monty's case, when he lost 25% of his blood volume, if we'd been able to measure flow, we would have noticed that decrease and we'd been able to intervene early. And obviously, over the last 20 years, we've had a number of devices that can now measure stroke volume, so we're able to do goal-directed fluid therapy and optimize stroke volume. And on a very basic principle of goal-directed fluid therapy alone, not the hemodynamics, the idea is if we can measure stroke volume, we can optimize patients on their Starling curve. If they're on the steep part of the Starling curve, they've got recruitable stroke volume. You give typically 250 mils of fluid, and they'll have recruitable stroke volume. Their stroke volume will increase by greater than 10%. Once they get to the top of their Starling curve, you give the same fluid challenge, and the stroke volume will no longer increase by 10%. And the idea as you go through the case is that you're able to optimize their stroke volume. It may take a couple of fluid challenges at the start to get them to the top of their Starling curve with 10% increases. And then you can stay there. If you have some blood loss and a decrease below whatever trigger you set, you can then use that as a time to give a further bolus of fluid. And this may be before you've actually seen any hypotension. You've just heard the surgeon's sucker.
Top Med Talk.
Now, if you're hearing this podcast maybe a couple of weeks after we released it and you didn't hear the live broadcast from the Top Med Talk website, you're probably going to feel a bit down about that. Here's the good news. You never ever need to miss another Top Med Talk broadcast again, because if you sign up to our mailing list, you will get alerts on your email when we're planning to go live. So www.topmedtalk.com and sign up for an email update on the website. As soon as you've done that, you will always be a part of Top Med Talk whenever we do a live broadcast. Also, of course, you can meet the Top Med Talk team, and the way you do that is you go to EBPOM, EBPOM, ebpom.org/meetings. Click on the little section on the website there. You'll find all of the events that we're going to be in attendance at. That's EBPOM, EBPOM, ebpom.org/meetings.